guidelines is clearly, you're selecting the patient, and when you're starting the regular funding, the loading dose should be 200 milligram. Then you follow up with a daily dose of 100 milligram IV, and the point that you get the first negative blood culture, that is the point.
Only 20 to 30%.
Okay. So what about patients for whom you don't have a blood culture? So you have to consider the first day of chemotherapy as a day of first negative blood culture. Continue for 14 days. But if you see that after 2 weeks, your patient, if you see that after 2 weeks, your patient is persistently febrile, the patient is not improving, then you need to think otherwise.
So what is the cost? We are very
Cost of enrollment?
Yeah.
I'm not really sure about the institutional costs, but the MRP of enrolment, that is Iraxis, which is sold by Pfizer, is approximately somewhere in the range of 9,000 rupees per vial. I'm not really sure of the
200
cost.
milligram.
100 is the target.
200 followed by 100.
Only 100.
200 followed by.
I'm not really sure of the cost, but when it comes to the cost, with the drug like caspofungin and micafungin, they have a higher cost, etc. But I will still request our commercial colleagues to tell you about the actual cost, which I'm not really sure. So, any other questions from the
Regarding de-escalation,
yes, sir.
if the patient has no previous azole taking, patient has a negative blood culture after 4 or 5 days, and if we can give the fluconazole in higher dose, considering the cost, because we have no blood culture facilities. So suppose the patient has no previous exposure to azole, and we have started the candidates, whether mica or caspo or whether angular fungal, blood culture has become negative. And if we continue for 14 days, then cost will be very high. Suppose after 3 or 4 days of blood culture negative, and previously patient has not been on azoles, so whether we can use the azole in higher dose like 800 or like that.
So actually, sir, the guidelines.
Guideline is different, but what is the practical? Why I am telling, because we have no facilities for blood culture, and if we continue for 14 days, it will be around 1.5 lakhs or like that.
I understand, sir. So at the point when you're starting an echinocandidate, your patient is moderate to severely ill.
Definitely.
If the patient is mildly ill, with no history of azole exposure, you're starting on fluconazole. But if the patient is moderate to severely ill, you're starting on an echinocandidate.
Right.
Now, once the patient is clinically better, and he can take the drug from oral route, according to the IDSA guidelines, the next drug that you should switch to oral confirmation is voriconazole. Not fluconazole, it's voriconazole. So once you can shift your drug, patient to oral, and you feel that your patient is significantly better, the infection load is far more less, you can switch to voriconazole according to the IDSA guidelines.
In what respect micafungin is better, anigular fungin is better than mica? In what respect?
See, actually, sir, there is no head-to-head clinical trial comparing any of the echinocandidates. So I will not tell you that efficacy-wise or safety-wise, the fungin is better than micafungin. But what I will tell you is that with fungin, the advantages are, as I showed you very clearly here, it has a better beta half-life. It achieves a steady state far earlier. It has a greater volume of distribution, and no dosage changes are required in case of hepatic or renal.
So that is applicable to both also, because mica and anigular.
This is applicable for micafungin, definitely.
No.
But if you have a look at this slides, it has better half-life and it achieves steady state far faster, which indicates that maybe killing ratio with enrolafungin would be better than micafungin, but I cannot conclude on that. Maybe according to pharmacological theories.
Particularly for renal patient, hemodialysis timing.
Yeah, it doesn't have the time because exactly. And again,
Go for this.
Yeah,
It is a non-digestible
and again, volume of distribution is far much more. So if you are considering a cluster infection or or kidney disease infection, this could be a benefit.
Another important guideline is for all patients who are getting candids or like that, that is when there is a disseminated candidal infection, you should do the ophthalmoscopy for every patient.
Yes, definitely.
That is one important
You
guideline.
should continue to do
Dilated,
ophthalmoscopy,
yes.
continue to check the esophagus, continue to check urine. So these kind of colonization or superficial infections are very common. One thing that kept on coming, I have attended the critical care congress which happened last week in Kolkata. So one thing kept on coming back throughout different discussions, how to start a preemptive therapy of candida. Candida score, it's not quite very useful. You see, they have given one score for TPN, one for abdominal surgery, one for colonization, and two for serious abscess. If you see your ICU patients, 90% of your patients will have a candida score greater than 2.5. You cannot start antifungal for 90% patients. So one thing kept on coming each and every time through the different discussions is that most important factor here is multifocal colonization. If you have a patient admitted with suppose growing candida in esophagus, growing candida in urine catheters, growing candida from the bedside lesion, that is a patient that you need to worry about. Because the patient's immunological state is down, candida is growing everywhere, it's present as a commensal, there is high chance that this candida will cause invasive infection. So when you are considering scoring system or whatever for candida, keep in mind the multifocal colonization. If you have a patient with three or more sites of colonization of candida,
Multifocal.
any of the other risk factors, that is the time you must start.
With a severe
Either with sepsis or in PTA with the central line. And the recommendation also says that very clearly, if the patient has a central line, remove the line as soon as possible. So, there is no further questions. I'll like to close